يمكن على مستوى المنطقة كلها. ومن الوحدة دي انتشر البودي انترفنشن في مصر كلها ويمكن في كثير من الدول العربية، وده بفضل مجهودات مجموعة كبيرة من الناس اللي موجودين معانا دلوقتي الحقيقة. الدكتور أسامة حتة، الدكتور سامح عبد الوهاب، الدكتور محمد غريب، الدكتور محمد شاكر، وكملنا نشاطنا في المركز الطبي العالمي مع الدكتور عماد القاضي الحقيقة. فاحنا الحقيقة كوحدة انترفنشن في البودي متميزين جدا. بيسعدني طبعا ان انا اقدم النهارده المتحدث الاول. The first speaker is الاستاذ دكتور محمد شاكر غازي، وهيتكلم على التيبس. What do you need to know and what is new. يعني قبل ما الدكتور محمد يبتدي عايز اقول ان الدكتور محمد بالنسبه للتيبس هو مش على مستوى مصر ولا على مستوى الدكتور محمد، على مستوى العالم. ويمكن متهيألي هو والدكتور غريب اكتر اتنين في العالم عاملين تيبس للبطكياري، وفي تكنيك مميز برضه بيقوم بيه. فالحقيقه احنا هنستمع الى واحد من اكثر الناس خبره في العالم في المجال ده. اتفضل دكتور محمد.
Thank you very much, Professor Dr. Ahmed Al-Durri, for your nice introduction. And dear professors and colleagues, you will talk about tips, what you need to know and what is new. As you know, in TIPS we create an artificial port systemic shunt between the portal circulation and systemic circulation by insertion of a metallic stent through the liver parenchyma, connecting between the portal vein and the IVC. The aim of TIPS is to reduce the port systemic pressure gradient, ideally to be below 10 millimeter mercury, because below this level the lymphatic system can drain the ascites and the hydrothorax, and the varices are not risky for bleeding, and these are the main indications for TIPS procedure. So what are the indications of TIPS procedure? Refractory variceal bleeding not responding to the medical and endoscopic management, refractory ascites, refractory hydrothorax, hepatorenal syndrome, chronic portal vein thrombosis, ده الانديكيشن الجديد اللي هنتكلم عليه النهارده, and TIPS can be used as a bridge for liver transplantation. Patient selection is a very important point in TIPS, as TIPS is a challenging technique with its complications, so we need to select the patients properly in order to enhance our results and reduce the incidence of complications. So patients with favorable outcome and improved survival after TIPS are patients with a bilirubin concentration less than 3, sodium more than 130, age less than 70, no history of hepatic encephalopathy, child score less than 10, and serum creat less than 2. On the other hand, patients with poor outcome and predicted 30 days mortality after TIPS, so patients to be avoided are patients with MELD score more than 18 and patients with bilirubin level more than 4 as single risk factor. These are the contraindications of TIPS. First, right side heart failure, because we increase the amount of blood going to the right side of the heart after insertion of TIPS, so the patient should be fit cardiologically. Active intrahepatic or systemic infection, because bacteria will colonize on the stent, leading to chronic infection and predispose to thrombosis of the stent. And then hepatic encephalopathy, because it will be worsened after TIPS. It is one of the most common complications after TIPS, if not the commonest. Hepatocellular carcinoma, especially if the lesion is in the path of the TIPS tract, to avoid seedling and spread of the HCC. Patient preparation is very important also in TIPS to enhance the results and reduce the possible complications. First of all, we should do duplex ultrasound examination. First, to confirm the diagnosis, if the patient is cirrhotic with portal hypertension, if the patient has Budd-Chiari syndrome, if there is HCC, and also to evaluate the blood vessels, which is very important for the success of TIPS procedure. So we confirm the patency of portal vein, hepatic vein, and IVC, and also to determine our access to do the TIPS stent. Liver function test, and the routine examination, routine investigations as CBC, coagulation profile, and creat, ECG and echocardiography for the anesthesia, and ascites tapping to facilitate the maneuver. Now regarding TIPS technique, we have 3 methods for TIPS insertion. First of all, the classic transjugular technique, which is used in post-hepatic or post-cirrhotic portal hypertension. Then DIPS technique, which is direct intrahepatic port systemic shunt, which is combined transjugular and transhepatic and used mainly in case of Budd-Chiari syndrome. And then the most recent technique, which is a transplant technique in chronic portal vein thrombosis. Starting with the classic tips, in which we catheterize one of the hepatic veins and puncture through the liver parenchyma towards the portal vein. First of all, imagine that we are at the head of the patient, which is the position in which we do the TIPS procedure. So this is the right of the patient, this is the left of the patient, and this is the liver. So this is the portal vein with its branches, right and left, and these are the right, middle, and left hepatic veins. This is the right lobe of the liver, and this is the left lobe of the liver. So again, this is the right hepatic vein, middle hepatic vein, and left hepatic vein. And this is the right portal, and this is the left portal. So if we want to puncture from one of the hepatic veins to one of the branch of the portal vein, we should know properly this orientation to know how to puncture toward the portal vein. So if we are puncturing from the right hepatic vein towards the right portal vein, we puncture anteriorly. If we puncture from the middle hepatic vein toward the right portal vein, we puncture posteriorly. If we puncture from the middle hepatic vein toward the left portal vein, we puncture to the left side. And if we puncture from the left hepatic vein toward the left portal vein, we puncture toward the right side. This is very important to know this orientation. So these videos will show us the classic TIPS technique. The first step is doing the transjugular approach by puncturing of the internal jugular vein, and we almost always do this under ultrasound guidance to facilitate the puncture. There is no need to do it blindly. This may lead to complication at the beginning of the procedure. So the ultrasound machine is beside us, so we use it to do the jugular puncture. Then we try to catheterize one of the hepatic veins. First, we catheterize the retrohepatic inferior vena cava and try to catheterize one of the hepatic veins, and usually the right hepatic vein is the easiest to puncture through it into the portal vein, and the right hepatic vein, its course is usually passing transversely, while the middle hepatic vein passes obliquely downwards and lateral. So we are here in the right hepatic vein. Then we try to puncture from the right hepatic vein through the liver parenchyma towards the portal vein. وهنوري دلوقتي ايه ازاي بنعمل targeting للبورتال vein till we reach the lumen of the right portal and confirm by contrast injection. Then we pass a guide wire and the catheter into the main portal vein and measure the pressure gradient between the portal circulation and systemic circulation. The portal circulation measured in the main portal vein and the systemic circulation measured in the IVC. Then we do dilatation of the tract by 8 millimeter balloon over a stiff guide wire. This followed by deployment of the stent. The standard diameter of the stents is 10 millimeter, and we start by deployment of the stent from below upwards, from the portal side up to the IVC side, and we almost always try to leave a considerable trunk of the main portal vein, because if this patient is subjected after that for liver transplantation, it will be easy procedure, and the upper end of the stent at the IVC. And take care, if you are catheterizing one of the hepatic veins and inserting the stent, the upper end of the stent should reach the IVC, or at least the junction between the hepatic vein and the IVC. Don't leave it in the hepatic vein, because this will lead to stenosis due to the jet of blood from the upper end of the stent into the hepatic vein will lead to stenosis at the junction between the hepatic vein and the IVC. So the upper end of the stent should reach the IVC. And then we dilate the stent by 10 millimeter balloon and finalize the procedure. And at the end of the procedure, you can measure again the pressure gradient between the portal vein and the IVC to confirm the reduction in the gradient. So how to do portal vein targeting? This is the most difficult step during the TIPS procedure and the most important step. We have many ways. We can do widget portal vein viewergram using CO2 or contrast and identify the site of the portal vein so that to direct the needle towards it. We can insert a wire inside the portal vein and target it. We can do a radiopaque marker marking the portal vein and also puncturing toward the marker. The IVUS is very expensive and not available. And the most easy and the most practical is the abdominal ultrasound guidance. وactually هو ده فعلا اللي احنا بنعمله في التبس. You are trying to puncture from the hepatic vein to the portal vein, and your assistant, we can see the probe here, can guide you and can guide your needle to reach the right portal vein. And very important to puncture the right portal vein in an intrahepatic location, not extrahepatic location, to avoid severe intraperitoneal bleeding. Now shifting to the DIPS technique, or direct intrahepatic portosystemic shunt, and we use this technique mainly in Budd-Chiari cases, because in Budd-Chiari cases which are indicated for TIPS procedure, they have occlusion of all hepatic veins, so we lack the guidance of the hepatic veins to puncture through them toward the portal vein. So we should puncture from the IVC directly into the portal vein, and it can be done by the classic technique actually, but it's very difficult in this case, so we prefer to do it with the DIPS technique in our institute. This video demonstrates how to do the DIPS technique. We insert the long 10 French cheese in the retrohepatic IVC, and then insert a snare or dormia basket. And then we do the most important step, which is creation of the track between the right portal and the IVC by direct ultrasound guidance. This is the tip of the needle, puncturing toward the right portal vein or right portal branch in an intrahepatic location. This is very important. After puncturing it, we do contrast injection to confirm the tip of the needle inside the lumen of the right portal. And then we do transfixation of the right portal and continue through the liver parenchyma. This is the track between the right portal and the IVC, and continue puncturing till we reach the IVC by the needle, as you see here. And this is the dormia inside the IVC. We can target it, getting into the IVC, and then we pass a guide wire through the needle to be snared by the dormia and get it out from the jugular axis. So we have through and through wire with one end getting from the jugular axis and the other end getting from the transhepatic axis. And then we dilate the track by 8 millimeter balloon, starting by the portal side, and this is the waist at the wall of the portal vein, and this is the waist toward at the IVC. After dilating the track by 8 millimeter balloon, we advance the cheese downwards to the portal and do portography. Then we pass a guide wire with a manipulation caster through the cheese and manipulate the guide wire toward the main portal vein, because this is the direction of the future inserted stent. And we keep this through and through wire for safety till we end the procedure. Portography, main portal, left portal, right portal. And then we deploy the stent as in the classic technique from below upwards. And then we dilate the stent by the 10 millimeter balloon and doing the final portography. And don't forget to embolize your track to decrease the incidence of bleeding after puncturing the liver parenchyma. And then the last technique, which is transplant tips in chronic portal vein thrombose. Previously, chronic portal vein thrombose was not subjected to any intervention, and even it was very difficult to do transplantation for those patients with low success rate and high complication rate during the procedure. في 2017 رياض سالم بدأ يعمل التكنيك ده transplant recanalization of the chronically thrombosed portal vein and the insertion of tips stent. وعمل البيبر بتاعته دي على 61 patients. السكسس ريت بتاعهم تكنيكالي كان 60 من 61 very high technical success rate, وبرضه clinical success rate كان very high أكتر من 90%. و almost half of these patients were subjected after that for liver transplantation, and the success rate was very high with end-to-end anastomosis in 96% of those patients. And the stent and the patency rate of the stent of 80% for 5 years with no incidence of thrombose, rethrombose of the stent after liver transplantation. And he concluded in this paper that portal vein recanalization and TIPS is a safe, effective, and durable treatment option for patients with chronic portal vein thrombosis who need liver transplantation. However, we can do it also in patients who are not on the waiting list for liver transplantation to reduce the portal hypertension, which is the main aim of TIPS procedure. طب ليه transsplenic axis؟ الستاديز اللي اتعملت قالت ان negotiation of the chronic portal vein thrombosis through the transsplenic axis is more successful than the transhepatic axis, so the transsplenic axis should be considered the primary method for recanalization of the chronically thrombosed portal vein. طيب ازاي بنعمل التكنيك ده؟ الاول بنعمل cross sectional imaging to identify the splenic vein and confirm its patency, which is essential in this technique, and identify the splenic vein tributary, which will be punctured through ultrasound guidance. And then we catheterize the splenic vein. This is a splenic vein, this is a superior mesenteric vein, and this hairline representing the chronically thrombosed portal vein. So we try to catheterize this chronically thrombosed portal vein. This is a guide wire inside the portal vein, and then the catheter, and then we inject contrast, and these are the intrahepatic branches of the portal vein, and these are the cavernous transformation surrounding the chronically thrombosed portal vein. After that, we insert a snare like that from this cheese from the transsplenic side into the right portal branch, and then target this snare from the transjugular axis as if we are doing the classic TIPS technique. We puncture through the ring of the snare, and then we pass a guide wire to be snared from the transsplenic axis. So in this case, we have a through and through wire with one end getting from the splenic side and one end getting from the transjugular side, as in TIPS technique, and then we insert the TIPS stent and dilate the tract. And as we see here, the portal vein is reconstructed after this procedure. This is a splenic vein, superior mesenteric, and portal vein, and this is TIPS stent. Complications of TIPS, the most dangerous is the bleeding, may occur in 14% of cases. However, it is life-threatening only in 2 to 3% of cases. Malfunction of the stent occur in 25 to 40% in the pair stents, and less common in covered stent, about 10 to 20% only. Hepatic encephalopathy, the most common complications, occurs 20 to 25% of cases. However, mostly it is controlled by the medical treatment. Injury of the surrounding structures, very rare with the ultrasound guidance. 30 days mortality, about 4%. Our take-home message, TIPS is a challenging, however, problem-solving, feasible technique with high technical and clinical success rates. Please be safe if you want to practice TIPS. TIPS technique is preferred in Budd-Chiari syndrome. Transsplenic TIPS is a novel technique offering hope with promising results for patients with chronic portal vein thrombosis and can be used as a bridge for liver transplantation. Thank you very much.
Thank you, Dr. Mohamed, for this presentation. We will leave the questions to the end of the session, and thank you for sticking to the time. Next, we will call Dr. Walid Hetta and Dr. Ahmed Bahauddin. They will talk about management of uterine fibroids, interventional